Hey everybody, welcome to the Whiteboard Doctor. We're a free open access medical education YouTube channel that tries to share relevant content with y'all for learners and peers and everything in between. For those who are coming to this channel for the first time, welcome. For those who are returning, welcome back. Please feel free to check out some of our other videos on our channel. Please ask questions, raise concerns, bring up additional points in the comments, and we'll do our best to respond to each one. We want this to be a community where we interact and learn from one another. So again, welcome. Today we're going to talk about tumor lysis syndrome. We'll go over what it is, some of the kind of epidemiology behind it, the pathophysiology, and that kind of drives everything else. So then we'll talk about how the pathophysiology relates to diagnosis, and then how we have to manage tumor lysis syndrome. So what is tumor lysis syndrome? Tumor lysis syndrome is essentially a syndrome when tumor cells lyse, releasing their intracellular contents into the bloodstream, and that release of intracellular contents in such a high volume, given the number of tumor cells, can lead to a lot of different problems: metabolic disturbances, renal insufficiency, dysrhythmia, seizure, multi-organ failure, and eventually death if it is super severe. So when do we get concerned for tumor lysis syndrome? Tumor lysis syndrome is highly dependent on the type of cancer a person has. So there are certain types of cancer that are more highly associated with tumor lysis syndrome. Also, it depends on tumor size and extent. If there's a very large tumor, there's very significant metastatic disease, all that can contribute to the risk for tumor lysis syndrome. So there's no hard and fast rule saying, only this cancer can cause tumor lysis syndrome, but typically the highest incidence is in high-grade lymphomas and acute leukemias. So high-grade lymphomas, let's write that out here, lymphomas and acute leukemias are highly associated with tumor lysis syndrome. For instance, if you are aggressively treating these in the hospital, the patient will be hospitalized, will get tumor lysis syndrome labs for monitoring each day, because there's a significant concern for tumor lysis syndrome in the aggressive management of high-grade lymphomas and acute leukemias, especially if they're rapidly progressing. All right. Additionally, bulky tumors and tumors with extensive metastatic disease. So again, this is just strictly volume of tumor cells in the body. So metastatic disease are going to be higher risk for tumor lysis syndrome once you start treating them. And tumors where you are initially treating them with significant aggression and intensity, right? So if you're being highly aggressive in your treatment, so increasing intensity of treatment will put you at increased risk for tumor lysis syndrome. A few other things, patients who are dehydrated, patients who already have a nephropathy. Ooh, nah, that's supposed to be an N. Nephropathy. Good. Patients who are hypotensive or have other comorbidities are at higher risk for tumor lysis syndrome because their body cannot compensate for the lysis of these cancer cells in the same way someone without some of these comorbidities would. Okay, so you have a patient with high-grade lymphoma, an acute leukemia, a bulky tumor, metastatic disease, you're treating them aggressively, etc., etc. You're worried about tumor lysis syndrome. Then you're like, well, what exactly is tumor lysis syndrome? Honestly, the concept and pathophysiology behind tumor lysis syndrome is extremely straightforward, because what you're doing, as we said, is you're lysing cancer cells, and you're lysing cancer cells in high enough volume where their intracellular contents released into the bloodstream are going to cause problems. So I drew a beautiful cancer cell here. All cancer cells are blue, if you were curious, obviously kidding. And then I wrote kind of the four intracellular contents that we get worried about that spill into the bloodstream. So one is going to be cytokines. Two is going to be, we're going to do this back here, intracellular potassium. Three is going to be nucleic acids. And four is going to be phos. And the spillage of these four things into the bloodstream can explain pretty much every part of tumor lysis syndrome. So first, hyperkalemia. So tumor lysis, oh, that is cytokines. Good, already messed it up. We'll still start with potassium down here. So hyperkalemia. So a big concern with tumor lysis syndrome is hyperkalemia and the resulting dysrhythmias that can occur. Dysrhythmia. That looks about right. Someone can comment on my terrible spelling if it isn't right. Um, Another thing we worry about is hypotension, inflammation, multi-organ failure. And this can be from the spillage of cytokines, right? So cytokines are inflammatory molecules. They cause inflammation in the body. So all these cytokines spilling out into the bloodstream, it can cause a shock state. Hypotension and then MOF, multi-organ failure. You can honestly think of it as any shock state. Septic shock is not caused by the bacterial infection. It's caused by the immune and inflammatory response to the bacterial infection. So when you spill all these cytokines out into the bloodstream, it can cause some of these systemic inflammatory responses, such as hypotension, inflammation, multi-organ failure, and all the things that come with a robust inflammatory response. Okay, good. And then we have, this is DNA, if you didn't notice, that beautiful double helix there with the bridging green lines. So I'm going to do, DNA, which is nucleic acid. And then what's important here is that this is actually broken down, right? It's broken down into purines by xanthine oxidase. So we'll do purines, and we're going to abbreviate xanthine oxidase XO, and this is going to be relevant later on for management. And then purines are further broken down by xanthine oxidase again into uric acid. All right, so again, xanthine oxidase XO. High levels of uric acid in the body can lead to crystallization in the nephrons, so renal crystallization, which can lead to nephropathy and kidney failure, right? And it can also cause some renal vasoconstriction, which decreases renal blood flow and worsens vasoconstriction. Nice one by me. Okay. Which decreases blood flow and can worsen the nephropathy. So the big thing with the spillage of nucleic acid is their conversion to purines and uric acid, which then can crystallize in the nephrons, leading to nephropathy and renal failure. Okay, last thing is hyperphosphatemia. So you have a large amount of intracellular phosphate, and spilling that, you can get hyperphosphatemia. Phosphatemia. Okay, big words today. What can hyperphosphatemia do? So honestly, the hyperphosphatemia itself does not cause that big of an issue, right? You'll see ESRD patients who are hyperphosphatemic, and yes, you give them some medications that decrease their phosphate, but the increase in phosphate itself is not the big concern. It's what it leads to, and it leads to secondary hypocalcemia because the phosphate and calcium precipitate together. So I'm going to just do, this is a calcium phosphate precipitate, which then drops the calcium. And that can kind of lead to twofold problems. One, the hypocalcemia, nice one. The hypocalcemia itself can cause neuromuscular irritability, right? You can get all those things. You think about tetany and etc. So neuromuscular irritability, I'm going to say irritable. This can also lead to dysrhythmias and seizures. So dysrhythmias and seizures. The second part of this is that the calcium phosphate itself can precipitate in the kidneys as well. So precipitate in kidneys, leading to nephropathy. So not only do you have uric acid, but you have calcium phosphate precipitating throughout the body, specifically the kidneys. So these are the 4, and I can even say 5, right, because it's hyperphosphatemia and hypocalcemia, main problems with tumor lysis syndrome. They're all traced back to the releasing of that intracellular content. So if you just think of what's inside a cell and what would happen if you had large volumes of those outside in the systemic circulation, then you can pretty much get to the problems with tumor lysis syndrome. So just quickly, I just want to go through, let's switch over, we can make this blue. I do just want to go quick diagnostically because we have all this out here. So how do you diagnose tumor lysis syndrome? And it is a diagnosis that you can just think about with certain lab derangements, but there is a formal, we call it the Chiaro-Bishop classification. Chiaro-Bishop classification. Good. Classification, which essentially says that you need greater than or equal to 2 of a range of lab derangements, and that is uric acid greater than 8, I'm going to say uric greater than 8, phos greater than 4.5, phos greater than 4.5, potassium greater than 6, calcium less than 7, and that's non-ionized calcium. Ionized calcium would be less than 1.2, but we won't write that on here. And they say that this should be either 3 days before chemo or less than or equal to 7 days after chemo, right? Because that's when you're going to be lysing a lot of these cells. There are clinical things within the Chiaro-Bishop classification, such as AKI, seizures, cardiac dysrhythmias, etc., but you're not going to get those without these lab derangements. So greater than or equal to 2 of these lab derangements. So on these patients, you should be sending off uric acid, phos, potassium, calcium, and if you have greater than or equal to 2, so 2 or more of these derangements per the Chiaro-Bishop classification, this patient would have tumor lysis syndrome. Okay, so I went over what it is, the pathophysiology behind it, the diagnostic criteria for it. There is a risk stratification kind of algorithm that can look at patients who are at high risk for tumor lysis syndrome and then how to kind of empirically or prophylactic treat them to try to prevent it. I'll let you guys look that up on your own. You know, it's all over the internet. I don't necessarily think it's worth kind of going into here. The other thing I did really want to talk about, though, was the management of tumor lysis syndrome. So I'm going to erase most of this. Actually, yeah, let's erase. Well, no, we're just going to scroll down. Let's do this. We're scrolling down, and now we'll talk about management. So you've diagnosed tumor lysis syndrome. Now what do you do? And management, much like diagnosis and much like the pathophys, is kind of a response to the spillage of the intracellular contents. So when we talk about management, we can think about the different things that can go wrong. So the first part of management is intravenous fluids. So why do we do this? We want to improve renal perfusion and GFR, which will minimize acidosis and decrease, uric acid crystal precipitation, right? So the whole point of this is to try to flush the uric acid through the kidneys without it precipitating. The goal is 5 to 6 liters of fluid per day, or 2 cc's per kg per hour of urinary output. So that's about 140 cc's per hour for your average sized person. There's some evidence in rat models that using diuretics, such as Lasix, which I did a video on Lasix, I can link it up here if you want to take a peek at that, and other loop diuretics, that using these to meet your urinary output goals can be helpful, but there's no studies in humans that say it's helpful. So if you're not able to meet your urine output goals, whether it's because there's renal failure, heart failure, etc., you can consider the use of diuretics, but again, under the understanding there's no human studies that say you need to. Okay, so intravenous fluids for your kidneys. What else? Allopurinol. So why allopurinol? If we think about the spillage of the nucleic acids into the bloodstream, we're not worried about the nucleic acids, we're worried about the uric acid. And how do nucleic acids get to uric acid, right? So we'll do DNA, remember, it was xanthine oxidase to purines, xanthine oxidase to uric acid. What does allopurinol do? It inhibits xanthine oxidase. So by giving allopurinol, you will stop this conversion to purines into uric acid and thus decrease the amount of uric acid. The trouble with this, though, is that the existing uric acid that is already in the bloodstream will still be there, right? The allopurinol doesn't do anything to get rid of that, and it can take up to 2 days for all this uric acid to be excreted. In addition to that, You can still get xanthine nephropathy, so it does not necessarily prevent against xanthine nephropathy or get rid of the current uric acid, but it will stop the continuance of production of significant uric acid through xanthine oxidase. Okay, so related to this then is rasburicase. So you've probably heard of allopurinol. There's a chance you've never heard of rasburicase unless you've spent clinical time on a hematology oncology floor. So what does rasburicase do? Once you have uric acid, the body on its own will get rid of uric acid through the urine. It also will convert some of it to a benign molecule, I shouldn't say molecule, to a benign multimer called allantoin. So allantoin, again, is benign. It doesn't precipitate in the kidneys or anything. And what causes uric acid to go to allantoin? Rasburicase. So giving rasburicase will actually take all that uric acid that's already produced and will produce it to this benign molecule allantoin. So it is a good, very helpful medication to give in tumor lysis syndrome, and even empirically to prevent tumor lysis syndrome as well. One thing to note is to be cautious in patients with G6pd deficiency. G6pd deficiency. The reason being is that H2O2 will start to build up because it's a byproduct of this uric acid to allantoin breakdown, and this can actually cause methemoglobinemia. So H2O2, which is peroxide, a byproduct of this uric acid allantoin conversion, can lead to methemoglobinemia in people with G6PD. So oftentimes these patients will have a G6PD sent off on them before you start treatment for their cancer if you are concerned for tumor lysis syndrome, but not always. And honestly, you probably should give rasburicase for a patient with significant tumor lysis syndrome, even if you haven't sent off a G6PD, because tumor lysis syndrome is life-threatening, and the G6PD assay can take a while to come back. One thing to note is that another thing people sometimes talk about is alkalizing the urine. The reason being is because uric acid is more likely to precipitate in an acidic environment. But I'm actually going to write this because this is important to know. So I'm going to do this because it's a don't alkalize the urine. So this would cause less precipitation of uric acid, but it will actually increase the precipitation. Okay. Increase the precipitation of calcium phosphate crystals in the urine. So it decreases the solubility of calcium phosphate. So do not do it. Cross out. Good. Now, the additional management, so all the next things are just treatment of the electrolyte derangements themselves. So for increased potassium, you want to do things that you would do for increased potassium. And I can do a video on hyperkalemia and the management, and you could refer to that. Once I finish it, I can link it up there. But you're going to give insulin to shift the potassium back into the cell. You can give high-dose beta agonists, which is like albuterol. It'd be like 20 milligrams, which you could argue is helpful or not. And then calcium gluconate, which stabilizes the cardiac membrane in hyperkalemia. All right, other things. You can give IV calcium for hypocalcemia. Be careful with this though, right? Because this is just like alkalizing the urine. It's kind of a rock in the hard place. Too much calcium will increase the calcium phosphate precipitants, right? You're giving more calcium, which is then available to bind with the phosphate. So what you really want to do is just give enough, the absolute lowest dose of IV calcium to resolve any clinical symptoms. So I'm going to say low dose based off of symptoms. Giving too much will make the calcium phosphate precipitants worse. You can give phosphate binders. There's not any good evidence really to say that this is helpful, but you could do phosphate binders. They're fairly benign. They don't have a lot of side effects. So, and then at the end stage, dialysis. And dialysis will help you manage the potassium, help you manage the uric acid and flushing through the kidneys. It won't take any of the phosphate out, but primarily it will help with fluid status stabilization, and then the hyperkalemia. So, tumor lysis syndrome overall, there's a lot to it, but it's fairly straightforward in the extent that if you just start with the cell and the intracellular contents being the phosphate, the potassium, the cytokines, and the nucleic acid, and then everything that would result with those four things being in circulation, you can go and figure out what the pathophys would be, how to diagnose this, and then how to manage it by targeting all of those things. All right, so that's tumor lysis syndrome. Please put your thoughts, questions, concerns in the comments, and we'll do our best to respond to them. Please subscribe to the channel if it's of interest to you, and please check out any other videos that might pique your curiosity. I hope you all have a good day, and thanks for listening.